Could you give a thumbs up if you could hear me? Oh,
Okay.
great. Awesome.
We can hear you.
Okay.
Loud and clear.
Okay. Okay,
There you
looks
go.
like we're set to go. So we will call the meeting to order. So we'll, just a couple reminders for those of you on the Zoom call. We will have time allotted for public comment. We're going to take public comment from the people in the conference room first, and then we'll take comments from the people on the Zoom call. Also, if you are not speaking, if you could place yourself on mute, that would be very helpful. And if you want to make a public comment, use the raise your hand icon on the Zoom to do that. And if you are attending the meeting via a phone call, you need to enter *9 on the keypad, and that will turn your audio on. So with that, we can start. Let's start with introductions in the room.
Sam Ballesteri, retired EMT.
Dr. John Burley, EMS Medical Director for Monterey County EMS Agency.
Teresa Rios, EMS Director.
Jeff DeAndrea, EMS Agency, and Mohawk.
Deborah Hopgood, EMS Analyst.
Kimberly Hernandez, EMS Analyst, EMS Agency.
And I'm Carla Spencer from Hospital Administration and the chair. So we will go to item 2, public comment. Oh, I'm sorry, introductions on the Zoom. I'll get to that. Apparently, I'm bored.
Tina Nieto, Law Enforcement.
Sorry,
Harry
guys.
Robbins, Citizens Rep.
Roxanne Seepersad, EMS Agency, EPI.
Mike Esslinger with AMR, the ambulance provider.
Jim Weinborg representing BLS Fire.
Joe Cafaro with the Hospital Council.
Susan Fletch from County Counsel's Office.
Steve Brooks, EMS Agency staff.
Michael or BLS Fire.
Leanne Magoski, Emergency Communications, and new to the committee. Thank you.
Welcome.
Get everybody?
No, because we don't have all the members.
I think there's 2 more we're waiting for.
Yeah, so this is, there we go. Finally, thank you. Paul Wood, representing city managers,
Great,
city manager of Greenfield.
thank you.
Tino's on the line. I don't know if he has audio access. It's in the Q&A that he does not have audio access.
I finally got joined correctly. So Tino Orion, AMR operations.
Okay. All right, now we can move to item 2. I'm so sorry. We are at public comment. Any member of the public may address the committee for a period not to exceed 3 minutes on any issue not on the committee's agenda. Sorry, I'm looking at the wrong agenda. The EMCC will listen to all communications but may not take any action. So first in the room, any public comment?
I suggest that we have 10 seconds of silence for the loss of first responders and all the public safety personnel we've lost.
Sounds good. We can do that. Thank you so much. Anything else from the room? Okay, we'll move on to the Zoom call. Does any public comment on the Zoom call? Okay. We'll move to item 3, approval of the past EMCC meeting minutes. And I will.
I move approval.
Thank you, Harry. Second?
I'll second Harry's approval.
Okay. Any discussion? Let's do a roll call vote. Please vote aye.
Aye.
Tina Nieto, aye.
Harry Robbins, aye.
Jim Langborg, aye.
Paul Wood, aye.
Tino Oriano, aye.
Mike Urquidez, aye.
Mike, I think, did you vote, Mike?
I did. I'm sorry. I raised my hand too, but
Oh,
yes.
I'm sorry, Mike Esslinger?
No.
I actually don't believe that I'm a voting member. I think that
Oh, okay.
I was the active member.
Paul Wood.
Oh, Paul Wood?
Yes, I voted aye. Right
Oh,
up
okay.
to Borg.
Okay, and I, Carla Spencer, vote aye.
Okay.
Okay, on to the next item, reports. So we have reports in the packet from the MAC Operations Subcommittee, EMS Agency. Do we want to go with each of them, or is it just
No,
in the
just
packet?
the
Okay.
packet for reference.
Emergency response to COVID-19 and the contract compliance working group.
So for just the A and B are the only ones that we do attached, and
Okay.
and then we do have.
Oh,
presentations
responsible
for
for C. Okay, so let's go back to Teresa for the EMS agency report.
Thank you.
Thank you.
And if you could please place yourself on mute, that would be great.
So attached to your agenda packet is a staff report that outlines some of the accomplishments of the EMS agency since we last met in November. I mentioned before that, you know, a lot of what the EMS agency does happens so much in the background that most people are unaware of all the work that this team does. And so this is our effort to make sure that our committee members are aware of what we do every day. My first, I do think this is a big accomplishment for the agency, is that we have filled our two EMS analyst positions, and we want to welcome both Deborah Hapgood and Kimberly Hernandez, who joined the team at the end of 2020. Both of them have very, very strong skill set and experience in EMS. And they are already making a very positive contribution to the agency and therefore to the system. One of the things that always excites me about having new members join the team is that fresh perspective. We get so caught up in day-to-day and in the habits that we form when we perform our duties that, you know, it takes the new people to question things in a different way. And I think that very soon, even today, you will start to see some of the changes, some of the impact that these individuals will have in the agency, along with, you know, of course, Jeff, who has been performing the role of the MOAC since he joined us as a temp. Well, back in July, and then as a permanent member of the team at the end of October. But in addition to that, we want to report on the local scope of practice. Just as a way of background, in October, we were approved for a local scope of practice for the paramedics to be able to administer the COVID-19 vaccine to EMS personnel and to the public. Since then, we released the materials so that agencies could apply. And we have approved applications from Monterey Fire and the City of Salinas. And Jeff has an update regarding some more possible pending applications. The other is that we also submitted an application to authorize EMTs to administer the COVID-19 vaccine to EMS personnel and to the general public. And the staff report says that we are waiting for approval from the state. We received that yesterday. In addition to that, we learned of a reimbursement opportunity if EMTs and paramedics are utilized to administer the vaccine to the members of the public. I don't have a lot of detail on that right now. We started acting on that yesterday. I do want to recognize Steve Brooks, our EMS analyst, for all the work that he's done. He's taken the lead on both of the local scope of practice applications and working with the state so that we can get the approvals and preparing the application packet so that they can go out to the agency so they can apply. And Jeff has worked diligently to expedite the approval of the applications that have been received, and even working with the entities that are interested in applying under those local scope of practice that we have. Closing the loop, we amended the bylaws to create an ex officio position for the director of the Monterey County Emergency Communications Department to serve on the EMCC, and that got approved on November 5th. I think as we were meeting in this room. I mentioned that now that we have two EMS analysts, new EMS analysts, that they're already making a positive contribution. We are now able to move forward and process more of the UOs that are coming in. Being so short staffed, things were taking a little longer in some cases, but since they've been here, and I must say, Deborah Hopgood has taken the lead on that. Jeff was also helping in that area before we saw the uptick in COVID and in MOAC activities just started increasing. Since November, we also have processed 27 EMT applications and 20 paramedic accreditation or reaccreditation applications. We continue to troubleshoot the notification process for when first responders are possibly exposed to COVID-19. We started working on that, I believe August, implementing a process to make sure that the hospitals were notifying the first responders. And, we noticed some gaps here and there, and we've been tweaking that. Kimberly Hernandez, one of our new EMS analysts, the last communication that we had from two of the fire agencies that said that they were not being notified. We found out that at least one of the hospitals didn't have access to the complete PCR. They had sort of a summary of the PCR. So the section that shows the agencies that are involved in when there's a response, they were completely missing that information. So Kimberly worked with our vendor ESO and coordinated also with the hospital to make sure that they had access. And at the last Fire Chiefs Association meeting that I attended, it seemed like things are running smoothly at this time. And so we hope that continues. Those are the ones that items that I wanted to highlight. The rest of them are on our report, and I'm happy to answer any questions you may have.
Any questions on the Zoom? Yep. Okay. Thank you. And we will now move to Mr. Jeff DeAndrea for our emergency response to COVID-19.
Thank you, Carla.
Just got that in the email.
Alrighty, so I'm going to sort of, we had invited Nick Steller from the Health Department to give us a update on the state of vaccine planning. And I'm going to sort of substitute for him a little bit here. We're working through phase 1A quite well. We are not touching phase 1B yet. We haven't gotten there, but we're working through the majority of healthcare providers in the county. We've gotten, I would say, all of the large groups and facilities have been taken care of through various means. We've had specific coordinated outreach programs, but also today, for example, every day this week, the health department's been standing up mass vaccination clinics for people in phase 1A for various healthcare workers. There are some challenges with home healthcare providers and some of the very small agencies and contractors that are not part of larger organizations. That's going as well as really can be expected. I can say firsthand, I'm witnessing how much time and work health department officials are putting into this. And some of the things that we hear about the slowness, it's actually very impressive what's been happening. I want to just emphasize that because the planning coming out of the blue is it's really quite impressive what's been accomplished so far. For the Mohawk, or the MOAC, as they say, at this point, we've fielded and fulfilled over more than 1,400 requests for PPE and other products. We're playing a very crucial role for several facilities with obtaining PPE. Right now, there are certain challenges where small entities are just unable to compete with hospitals or skilled nursing facilities, and the allocations for certain products are such that even larger facilities are having trouble finding things. We've gotten to a place where reliance on the state and Cal OES for certain products is quite real, and there's no way around it right now. Excuse me. The MOAC role, which is really more than me, has been putting a lot of energy and attention into staffing requests. We're trying to get RNs, CNAs, LVNs into facilities, the 4 hospitals and our skilled nursing facilities. That's a challenging process given the statewide nature of the crisis, and there's staffing challenges everywhere. I'm not really sure where to with the camera. Pardon my, I'm scattered. So yeah, the statewide nature of the crisis is such that the demand for nursing staff has just simply exceeded the available supply across the state everywhere, and everyone's hit really hard with that. The Mohawk channel has also been fielding some durable goods requests. We've gotten oxygen concentrators to a skilled nursing facility and Natividad. We just today we've have some high flow respiratory support systems, kind of adjuncts to ventilators that are arriving in county today. Also for Natividad, which has been hit particularly hard, as has everybody, of course. We are also continuing to do what we always do, which is make sure that we've got the swabs, testing kits, viral transport media that the labs in our county need to keep testing. And we're keeping those things flowing, and also monoclonal antibody therapeutics are coming into the county. And thank your colleague Rob Ferris again for coordinating all of that and taking care of the coalition, which is you guys are, SVMH is really committed to a great leadership role for all the hospitals. We've gotten into fit testing equipment. We procured some concrete barriers to protect Salinas Valley Memorial's on-site COVID testing tent after an unfortunate car accident. And really the bottom line there is that the MOAC channel is starting to just field a range of requests, and the activity is getting a little more and more diverse all the time. And lastly, but not least importantly, as Teresa mentioned, welcoming Deborah, and I want to acknowledge Deborah arriving as sort of a MOAC partner. We're getting her into the role as well because it's there's a lot going on right now for the MOAC role. And I can take any questions if anybody has any.
Jeff?
Yes, sir.
How are we doing on first responder inoculations? What percentage roughly have we got to?
I don't have a percentage for you.
Okay.
So we've authorized, as Teresa mentioned, Monterey Fire and Salinas Fire for their paramedics to administer. We're also working with Hunter Liggett, so they're going to be handling some of the general public in South County. I don't have numbers. I know that I've spoken to folks on the peninsula that we're seeing like a substantial, if not majority of the firefighters have had access and had their first dose. Law enforcement is in
The second group.
yeah, another lower, I don't want to say the word lower, that's a provocative, but the next tier to be served. So we haven't got there yet. And I imagine within 2 to 3 weeks, we're going to see pretty much nearly all first responders that want to be vaccinated have received their first dose at the least. And by another 2-3 weeks, some will have received their second as well.
Thank you.
Just a general observation. I hate to be a naysayer here, but I think you're deficient in public information. There's a growing frustration. It's appearing in the editorials in the newspaper or what have you. The information flowing out to the average citizen is next to nil. You're dealing right now, and I think commendably, with selected groups, the firefighters, the EMTs, what have you. They're relatively small and controllable groups. You're approaching the state where you're going to be going into 1B and 1C, where you're going to get more of the general population, and the information is not forthcoming here. Having Dr. Marino get on the TV for an interview and mumble a few words is not public information. You've got to put it out in black and white so people can read it, interpret it, and have some sort of tangible actions they can take. I know that there's a lot of indefinite aspects to this, particularly from the state, but your public information, in my estimation, is not up to speed right now, and that's going to have to change, particularly as we get downstream.
Yeah, Harry, I think that sentiment is common and widespread, not just here, but all over the state. And I will certainly, the emphasis with which you share that, I will pass that on to our PIO. That's not my place personally to reach out to the public, but I can share that with our PIO. I'll just share that the challenge we have, we keep using the metaphor of building the ship while we're sailing or building the aircraft while we're flying, is that the information we get from the state as far as allocations and whatnot is literally the week before and the day before. Yeah, we really wish that we had more time to provide more prepared messaging for the public, and it's an ongoing challenge for sure. And your point is well taken about the other tiers. When we get into larger groups and the general public, there will definitely be some challenges. But yeah, point well taken, and I will share that.
Mr. Chair, it's Tina Nieto. Hey, I know is frustration. Can I just pass on that? I know the county's doing the vaccination town hall meeting. It's gone out through the internet. However, the big part of the population as we move into 1B is the elderly or our seniors who are not very proficient. Well, I shouldn't say that. That's generalization, but from what we've found is that they're not on the internet. They're not as social media savvy. It's getting better, but maybe we can, partner with our local TV stations, also the cable stations for all the different communities, and also get out the information to be announced at the city council meetings before the meeting, because I know it's coming up shortly, to maybe hit that part of the population, because I think the information should be coming out of one place. So because that's where it gets confusing. It's kind of, we're all spinning in different directions. So
could I comment on that too, Tina? You're absolutely right on. The thing is that we're in a medical emergency. The JIC should be up and operating, Joint Information Center, and the information should be flowing from there. It should be tangible. It should be authoritative. It should tell people ahead of time, hey, we are not going to be reaching 1B or 1C until approximately this date. I know that we are loath to put out dates, but when we do, here's what's going to happen. You will find out the information from X, Y, and Z, and you may make appointments or how this is going to be standalone, whatever have you. We need to be more authoritative, and there's a comfort zone that is not being touched here as a result of I'll say deficient public information.
And I would agree with that. I think at the city level, it's so imperative. People are coming up every single day wanting to know when it's going to be available. And I get it too. You guys don't even know. But the more that everyone understands that there is a lack of information, the more they understand, okay, they're in the same boat that we are. That information has to get out.
Paul, I find there's more information on the daily emails that come out from the city of Monterey than from the county. And that's sad. Now, something is radically wrong and with the PIO or whomever, and we've got to start thinking in terms of the principles of crisis communication and the media and get the information out.
Right. Agreed.
Duly noted, Harry. Any other questions? Comments?
Thank you.
Thanks.
I think I say this every meeting, but to work with Jeff is just a complete
Oh,
pleasure.
thanks.
He does so much for the hospitals and coordinating and getting us supplies and things we need. And so I can't, and I know I speak for lots of people, can't thank you enough for all the work that you've
I
done.
appreciate your words, Carly, and I want to just send it right back to, Rob and Judy you have great managers that are very involved and committed, not just to your hospital, but to the whole community. They really are.
Thank you. Yeah, we have a great team. So anyway, thank you, and more to come. Okay, so we will now go on to our contract compliance working group. Is that going to be
Roxanne.
Roxanne?
That's me. Hi.
Oh, hi, Roxanne.
Can you, I'm gonna share my screen here. Okay, so this is the compliance from January through October. The last time that we met, we talked about some of the challenges that we were having or we saw in priority 1. And you can see from the July until October, priority 1 continues to be under 90%. And it is partly into those challenges that we discussed before with staffing and attending to like lower call volumes and just overall pandemic stuff. And in the green response area, you can see again similar trends. Priority 1 is under 90% all last quarter. Quarter 3 in October and October, and every other priority area seems to be doing okay at over 90%. And yellow, I think only priorities 2 and 3 were reportable in October, and they were at 95 and 92%. And in the orange, priority 2 was also mostly reportable throughout the year and over 90% as well. And for dispatch, everything here is pretty consistent. They're always well under that 59-second standard. There was a slight uptick in August, but it seems to be going back down to the usual like 36 overall. And that is my very brief review of what's been going on in the response time compliance. That's it. Thank you.
And if this is Mike, if I could just make a quick comment as well, just kind of tagging on to the last meeting and some of the concerns that we had raised. I did want to state that, while we are, in disagreement over the new compliance metrics that had been established, with the revisions of the MPDS standards, we have been working collaboratively with the county. They stated that they're open to solutions that, we feel might establish a more reasonable metric relating to priority 1 compliance. So at this point, we have a local, regional, and even our national team. They've been performing a real in-depth analysis, and we expect to have some proposals to the county maybe as soon as next week. So I just wanted to, thank everybody. We appreciate the focus on this and especially taking our perspectives into account. So thank you.
Does Kim have? We have
Kimberly,
two
no.
other presentations related to contract compliance.
Okay.
If you don't mind, Kimberly.
You want me to do it all right now? Or do you want me to do it all right now?
Yes. So following is a further information on contract compliance. It has to do with MPDS and APOT times that Kimberly is going to provide. And then after that, I can expand a little bit on the priority one response time compliance.
Okay, sounds good.
Yes, please.
Okay, so good morning. This is some data that we've collected on system monitoring. And you can go ahead and go to the next slide. So first is the MPDS performance 2019 to 2020 comparison. There was an increase in calls EMD'd after the MPDS policy change in November of 2019. The percentages increased up until June, and then they started to decrease after June, and we started looking into why. When we started to drill down, we started comparing amount of calls, sorry, I can't see, aborted prior to getting a determinant code. The number of aborted calls had increased significantly since the start of COVID. We believe that interrogation time is extended due to the AIDS, the emerging infectious disease tool, COVID screening questions, which are vital for the responder safety. These questions are asked before starting the key question portion of the EMD, with the exception of CPR in progress, active childbirth, or active choking. Key questions must be answered before a determinant code can be assigned to the call. Many interrogation times have been lengthened due to COVID screening. The medical dispatcher is unable to finish the key questioning before help arrived. At that point, they cannot go any further. Help has arrived and the call is aborted. The call was transferred. The patient and/or reporting party received direction and instruction from dispatch until help arrived at their door. But these calls are still getting counted as not EMD'd. There's also likely more aborted calls due to the lift assist call type. The lift assist calls that have no medical necessity are aborted during case entry. We're working with AMR on how to determine how many of these calls were aborted due to lift assist. And you can go to the next slide. So currently on this slide, it shows the current calculation on how many calls, the percentage of how many calls are EMD'd. So basically it's the total call volume, and then the number of calls EMD'd is divided by the total call volume, and then you end up with the percentage. So this data is from September of 2020. So the current calculation, 53% of the calls were EMD'd. But total call volume includes calls that will never be transferred for EMD. Such calls are 5150, structure fire standbys, aircraft emergency landings, water rescues, and interfacility transfers. Also calls where PD is on scene requesting an ambulance or fire is on scene requesting an ambulance. So the proposed calculation is to take the total call volume and to deduct or subtract the calls that are never EMD'd. So on the right-hand side of the slide, you take the 3,110 and take away the 438. Now we have total calls 2672, and then that's divided, you take 1639 divided, and then it ups the percentage to give a better picture of how many calls are being EMD'd, because the dispatchers can't call EMD a call that they never received. You can go on to the next slide. This is APOT times. We've collected APOT data comparisons for 2019 and 2020. There have been increases in APOT times since July in the overall average and the 90th percentile overall. This is not surprising due to COVID cases increasing throughout the county. December has had the largest increase thus far in overall average and 90th percentile for hospitals within the county. And you can go to the next slide. Since July, there's been a steady increase with the SVMH, NMC, and Me Memorial APOT times, except for in September where SVMH had a 19% decrease. Times decreased across the board in September. According to the data, CHOMPS times have decreased April through December in comparison to 2019, which is great considering the challenges with COVID. March was the only month with a significant increase. And you can go to the next one. This is a call volume and transports comparison for 2019 to 2020. There was a decrease in call volume and transports April through June. March was the start of COVID. The numbers in call volume started to normalize in July and have continued to stay steady. And the numbers of transports started steadily increasing beginning in July and as of December had normalized. On the far right-hand side is the average turnaround time. The turnaround time is the elapsed period from at destination timestamp to the incident being closed timestamp. So the most notable increase in the turnaround time were in July and August, which were 17% increase from the previous year. Considering the situation with COVID, we expect to see increases in turnaround time due to decontaminating the ambulances and longer APOD times. According to the data, AMR has done a great job with moving their ambulances back into the system while faced with these challenges due to COVID-related delays. And you can go ahead and go to the next one. So some actions we have in progress for MPDS. AMR dispatch is starting to log instances where dispatchers feel a call should have been transferred for EMD. When we have tangible information, we'll meet with county communications to discuss these calls. We're working with AMR to quantify how many lift assist call types are aborted during case entry. And we're revising the EIDS tool to shorten the COVID screening so dispatchers can get into the key question portion of the EMD more quickly. AMR is working with county communications to create new call types for calls where medical was requested by police or fire and would not require EMD. In regards to APOT, field crews are advising AMR dispatch when held at the hospital due to APOT. AMR dispatch is logging this information into the CAD and relaying it to field supervisors so they are aware of a significant delay and can act accordingly. And we're working with AMR to establish more specific guidelines to address increase in APOT times. Does anyone have any questions or comments?
Yes, I've got one question here. Going back to the screen that you showed and the recommendations regarding removing certain types of calls from the EMD process. What does it take to get that done?
It's just a calculation. So when we run those numbers, those calls, the 5150s, the structure fire standbys, that's the actual call type that the call is coded as.
I'm aware of that. I'm aware of that. What I'm saying is, what does it take to eliminate those from the EMD process as proposed?
I think it's just in the same way that it was shown on the screen, where we take the total number of calls and then we will deduct those calls that meet that criteria of the type of calls that would never be EMD, and then adjust the total. That's all it takes.
Well, I guess, Teresa, what I'm saying is, does it require a recommendation or anything from this committee?
The committee, I don't know that it does, no.
Or an endorsement? Maybe an endorsement is appropriate.
Well, it is always nice to have the endorsement of the committee to do that, yes.
I'm having trouble hearing you, but
Yes, it is always nice to have the endorsement of the committee to move forward with a recommended action. We were, at this time, we were asked to bring some reports to the committee. So we were just, instead of a proposed calculation of the EMD calls, it was more of a report of what we see and what the difference, and just to show the difference, the impact that it has if we remove the cause, that we will never be EMD. So at this time we were not seeking an endorsement, but it was just simply a report, and just to get a sense of how the how the information is received by the committee.
all right, then that be the case, Madam Chair. I'd like to make a motion that we, as the EMCC, endorse the actions listed on this particular screen, and particularly stressing removing those items from the EMD process that were on the previous screen. I think this is a step forward, and it needs to be taken, and I like to see it done with all practical haste, if you will. So I make that motion.
Harry, may I interject here and then ask that if it's something that the committee wants to move forward, that we bring it back at the next committee meeting for appropriate action. And it will give us time also because AMR is right now working with communications to see if they can add more codes to identify calls that would not be EMD, but right now they're staying in a more of a sort of a general bucket of calls. So it would allow us enough time to fine tune that, get more clarification on those calls, get more accurate number of calls that perhaps could be not counted in the future, and then bring that back in March for appropriate action.
I would, that's acceptable to me.
Thank you.
I don't want to see this drop through the cracks is what I'm saying.
Okay.
Would the EMD recommendation be processed through the operations committee for endorsement?
It could be brought back to.
Yes, it could be brought back to them.
We could add it at the end as an agenda item.
But it's for another committee.
Yeah,
Yeah,
for the
different
it'll come back with making the same presentation at the next committee. It'll come back.
And Tito from AMR, I had a question on the presentation. I don't see it in our packet. Is the presentation available for the committee members to look at it a little bit closer? Because there was a lot of numbers on those charts. And the next point, the APOD times is just specifically for AMR. Did we also include, have you done analysis on the fire ambulances that do transport also that participate in that APOD time as well?
No, these times were on AMR times or on the AMR data for APOD, but I can add the fire transporting units as well.
Okay. And can the presentation be made available to the committee members? Just because there was a lot of numbers in there that I didn't really get a chance to analyze that stuff.
Yes.
I would support that.
Yeah, we can make those available. We can send them after the meeting to all the committee members.
Thank you.
Any other questions or comments? Okay, thank you. Okay, did you have?
Yeah, I wanted to follow up with some additional information regarding the priority 1 response time compliance. This is a presentation, at least something similar that was presented to the contract compliance working group after the after the November meeting when this item was first brought up. Estela, could you bring up the PowerPoint? Thank you. So I wanted us to give the same background information that we provided to contract compliance working group. It is clear from our November meeting that from AMR's perspective, the challenge in meeting response to compliance is the result of the change in the MPDS with the implementation of the call interrogation. In the meetings that we have had, we have worked very cooperatively. There's been very amicable, but we definitely see things a little differently. And I wanted to have an opportunity to explain to the committee why. One of the things that we have, the slide that we have here is a comparison of the priority 1 response times, the number of calls, the number of responses, and then the response time, the compliance achieved. So on the 2 columns to the left, you can see clearly the shift in the number of calls. So in 2019, between January and August, you can see the priority 1 had over 2,000 calls each month. Then so September of 2019, when the change was first implemented, we didn't consider it officially implemented until November because there were some hiccups in the system, I suppose. And but you can see that the drop from September to 650, and then from there steadily is been between 200 and a little and 300 calls. And so that is AMR's point, that because the call volume in priority 1 has dropped significantly that they have a bigger challenge meeting response to compliance. When we look at the data, however, we can see that even after the change, AMR has been able to meet response to compliance in priority 1 after the change was implemented. So the change was implemented, if we look at it from September of 2019, and you look at that column, the second from the right, you can see it's highlighted the numbers are in green, that in September, AMR reached 95% compliance in priority 1, November, 90%, December, 92, and then we go to 2020, it's still pre-COVID, 92%. And then March, the start of COVID, they still reach 90%. And then in June, in the middle of COVID, they reach 93%. We meet with AMR on a monthly basis to review the metrics reports that they provide. And in every single report, what they have reported when they have reached the response time compliance, it usually comes back to changes or adjustments that they have made to their deployment plan. So this is the reason why when AMR first came to the agency and proposed 2 solutions. Can you move to the next slide? I think that's where. Oh, so this slide, as I was mentioning, we meet with AMR on a monthly basis, and the primary reasons they list for not meeting response and compliance in priority 1 always come back to COVID-19, the wildfires that started in July, some increase in shoot times, which we started looking at the data just to see if it was, just how much those had increased, multiple out-of-county transfers per day, and there are some other reasons, including, that there were some the Black Lives Matter protests blocking roads and access to the highway. With the COVID-19, I mean, this is something that everybody's dealing with, that COVID-19 has affected the staffing. For AMR, it really goes a little bit beyond the COVID, the period of the COVID-19. Can you? Yes, and so with COVID-19, what we also see, and Kimberly already reported, is that we have an increase in APA time. And then there's also the time that it is spent decontaminating the units. During the meetings, AMR had provided us an estimated estimate time of between 15 minutes and 2 hours for the time that it takes to decontaminate the unit, which is one of the reasons why we started looking at the time.
Turnaround time.
Say that again?
The turnaround time.
The turnaround time, to see if we could quantify the time that is spent decontaminating the units. Now, the wildfires, as you know, we dealt with 3 big wildfires. AMR provided 6 standby units for the 3 fires, and that happened between July and October. So just with the low staffing, the units that were provided for the wildfires, we can see that there are several factors that are affecting the response and compliance. You can go to the next one. So what we have been working with AMR on our monthly meetings, and even meetings that we have held just to deal with this issue, to explore the options that could be available. We know that there's an ongoing challenge that AMR has. They are able to maintain their EMT staffing levels, as you can see here, when we go month to month, and this table shows the staffing for the last 2 years. Very consistently, they are at 100% staffing. But when it comes to the medics, we do see that their staffing levels drop. In 2020, particularly during the time of COVID, we've seen those numbers drop, significantly. So we know that there's a challenge there. When in AMR's reports, they have indicated that due to the low staffing levels, it becomes difficult to staff ambulances. So one of the things that they have told us is that At peak time, they are projecting 19 ambulances in the system. But there have been months when the reports show that due to the staffing shortages, there are times that they can only staff 14 ambulances. So any number of ambulances that are not in the system, then I think that we can safely say that may have an impact on response time compliance. So this is why when they presented a couple of solutions to the county, that the county, the EMS agency said we are open to exploring, but we believe that there's some that there may be some changes that AMR can implement. They can at the very least improve the response time compliance in priority one. Particularly because we have seen them be able to meet response time compliance in priority one in at least 5-6 months since the implementation of the changes to the EMPDS. Can you change it to the next one? So what is this? Yeah, so just to emphasize, the boxes that you see highlighted, those are each of the months when AMR was able to meet response to compliance in priority one since the implementation of the MPDS changes. That is why our position is that we want to work with them. We want to see what are the changes that they can make. We know the staffing is difficult right now for everybody, not just for AMR here in Monterey County, but I'm on phone calls with the state, with the LEMSAs, and everybody's having the same challenge. I mentioned at our last meeting that one of the ways that the other LEMSAs are dealing with the non-compliance when it comes to response times is that some entities, some LEMSAs are just watching them carefully and not assessing penalties. Others have issued a formal letter to the provider saying that at least during COVID, they will watch response time compliance, but will waive the response time penalties related to response time compliance. And we believe that that is fair. It is something that the agency has taken in consideration and is seeking some advice internally before moving in that direction. So, oh no, you can close that. Yeah, well, here, one of the things, during the meetings with AMR, one of the things that has come up is that they are very conservative when they submit exemptions, exclusions under the agreement. They don't want to abuse it, and we respect that. We appreciate that is the case. But the only thing that we said to AMR is that if they have a call for which they were late and it qualifies as an exclusion under the agreement, we simply saying to them, submit it. Submit it for the agency's review. The agency will do its due diligence to review the call and either approve or deny the call. And if they have questions, because they don't want to come across as abusing the contract, they can always pick up the call and let us know, if they have a question, does it qualify? One of the things that we want to stress, and we stress this to AMR, is that we are not suggesting for AMR to depend on exclusions to meet response and compliance. As a contract administrator in the past, I've been on the other side, I've been on AMR side, is that I use what is available in the within the language of the agreement, and as long as I stay within the what is prescribed in the agreement, then we should be okay. And I say that even if they were reaching 90% compliance, when I hear that they don't submit because they'd rather be conservative and not come across in a negative way, even if they were reaching 90% compliance, I say the same thing. They qualify, submit them. We'll review them and we work. We can clarify questions if there are any. I'm happy to answer any questions.
And this is Mike. If I could just make one more statement, and I did want to clarify for people, just so everybody on the committee also has some level of perspective, is that certainly we take full responsibility, recognizing that we are in a severe staffing crisis. COVID has created extraordinary challenges when it comes to quarantine and the ability on a daily basis to we have multiple sick calls, we have people that don't pass the FAST tool when they're coming to work, so we can't let them go on the unit. But one thing that I think is really critical is that when you're looking at the volume and the perspectives and the changes of the MPDS standards, is that this scenario that we're looking at is generally, on average, we're talking one late call a day. And I think that the margin of error is really, what we're challenged with, is that it's such, we recognize it's the highest acuity calls with the lowest response time standard. But with that said, that, still as the system, looking at it as a whole, you're looking at a small percentage of calls. And it's typically, the non-compliant months that you're looking at, these average one late call per day, and to meet that standard would be less than one late call a day. So that's all we're pointing out, is that it's a very, very stringent standard. But we appreciate, working together. We recognize that, we have some opportunities to also, bring some ideas to the table as well. So we appreciate it.
And the EMS agency recognizes that the change in the call volume. We want to be fair, we want to be objective, but we have a responsibility to do our due diligence, to look at everything before we make a change. One of the suggestions that AMR brought forward was to combine priority 1 and priority 2 for the purpose of response and compliance. And we requested that they take any month, and that they show us what that would look like. We want to be careful in moving forward and making any change to the way that response and compliance is measured, if we were to make a change. And before we do that, we need to do our due diligence. We really believe that there's some, we have to recognize that COVID and the fires affected the operations. One of the things that we did when we executed amendment number 10 that extended this agreement was that we waived the penalties because of the change to MPDS. We waived them for 6 months. And the agreement was that we were going to watch the data for 6 months. And depending on what that told us, then we would come back to the table and have further discussions. But we did not anticipate that COVID was going to happen. We did not anticipate that we were going to be dealing with 3 fires. And those two are major variables into what the change is, not just the change into MPDS that is having an impact into response and compliance. It is also COVID and fires and other things. But yes, we are open to the discussions. We are now moving quickly on it because we have to do our due diligence.
We have another question. I can't spell the name, but Guidance.
Guidance Panholzer?
Yes.
Chief Panholzer.
Yes. Is the EMS agency advocating for and supporting getting a paramedic training program up and running in this county? That is an important part of the solution to assist AMR and the ALS fire agencies in meeting staffing needs.
We are happy to entertain, we will entertain any solution and implement the ones that are viable.
Just a general comment. I appreciate all the attention that's going into this. And I sit here convinced that a lot of good people are working extremely hard, from a variety of different desks, if you will, from different positions, to address this issue and make it work. We're all adults, and we know we're dealing with a national crisis here, a national health crisis. And the the full impact of that and all the places where it bulges out in other issues, we have not fully explored. A lot of good minds and a lot of good effort is going into this. And I think we have to accept that. We can't let down, as pointed out by the doctor at the EMC, at the Contract Compliance Working Group last time, that one late call might have tragic results, and we can't afford that. So we have to continue to be vigilant and continue to work at this and keep it foremost until we're out of the woods, until we're out of COVID, which might be another year, and realize that any perturbation, whether it be fires, medical emergencies, whatever have you, may affect the overall performance. I think everybody is trying very hard to prevent that and minimize it, but it's going to be there. So I would say, let's move onward.
Jim Lineborg, BLS Fire, just a quick comment and then a question. Teresa, thank you for the report. And I'm trying to track everything that was being said, but if I misunderstood something, I apologize. But I believe what I heard was that AMR was able to meet the challenge of COVID in the months in the spring and in the late winter with the 90%, and then later they were unable to. And I believe, and if I heard this wrong, I apologize. I believe that was also used as like rationale. Well, if you were able to do it then, you should be able to do it now. Speaking purely from my agency's perspective, the initial months of COVID actually showed a decrease in call volume. And now we're seeing an increase, and your current stats are not on there. And I'm sure the call volume for everybody, including AMR, continues to increase. So I don't know if I did hear that correctly, that was really a fair or accurate perception of the call volume and how COVID is impacting AMR as well as other agencies. The other thing I have, or the other question I have is there something that exists in the contract that talks about exceptions or disasters or something like that, and how that pertains to meeting response time standards? Because it is my understanding that we are in a disaster now.
Thank you, Chief Lambert. You are correct. The overall call volume, we did see a decrease after COVID started. The lowest month that we saw was in April. And then we've seen some fluctuations, but call volume being almost back to normal in the last month. I think we were off, we were below about 3% when comparing 2019 to 2020. The difference was about 3%. The number of transports is where we see the bigger difference. When we compare 2019 and 2020, month to month, I think that by the last data that we had available, which was October, the number of transports were still about 10% lower than same period last year. Our position is not that if you did it then, you should be able to do it now. Our position is that we know that, that they have been able to meet response time compliance, even some months, even during the middle of COVID. So, and they have credited, what we are acknowledging is the fact that they have met it some months, and that the way that they have met it is by making changes to their deployment plan. So we want to explore those. In terms of what can be done in terms of a disaster, one of the things is Section 18 talks about the exclusions, and it does list specific specific circumstances under which AMR is able to submit calls for exclusion, and there's also language that allows for certain corrections to be made to the calls. They submit those on a monthly basis. That is the area where I indicated that AMR has said that they have been very conservative in their approach, and that they don't submit everything for which they may qualify, that a call may qualify for exclusion. We simply said to AMR, don't shy away. If you're reviewing the call and it meets the criteria under Section 18, by all means, submit it. The EMS agency is going to do its due diligence to review that call and either approve or deny the call. Now, even if when we deny the call, AMR still has an opportunity to, I just lost the word. Appeal, thank you. AMR has an opportunity to appeal that decision, provide additional information that maybe they did not provide during the initial submittal, and then we can review again. So it's not a one-shot thing when it comes to this, to them submitting calls for exclusion or corrections. I forgot my last point. Oh, in terms of disasters, yes, that was one of the things that we were consulting with internally with council as far as waiving the penalties. We see that that is being done up and down the state. Not everybody's handling those the same way. Some jurisdictions have actually issued a letter, a formal letter to the provider saying, because of COVID and the impact that this has had on all of the operations in staffing and in so many different ways, the EMS agencies are waiving the penalties during the period of COVID. Others are not issuing that letter, a formal letter, but they're also not assessing penalties. That's what we have done. During COVID, we have not assessed any penalties. We were considering doing something more formal, and that's where we are. But AMR in 2020, we did not assess any penalties. First, because when we executed the amendment number 10, we waived the penalties for a period of 6 months after the implementation of the call interrogation, that change made to MPDS. After those 6 months, after the 6 months were over, we were already in the middle of COVID. So, we've been watching the compliance. We are concerned. As I mentioned, the proposed solution was to combine, that AMR proposed, was to combine priority 1 and priority 2. And what that does is that, it will allow them to meet response to compliance. But we want to, this is still the priority 1 call. So we want to look at them more carefully, especially when there are calls that they didn't get there within the allowable time. Then we're drilling down and looking at the calls, because what we want to make sure that there's no impact to patient outcomes. So we're starting to drill down into that data, and Kimberly is with AMR. We're not doing that in a silo. On all of this, we're working closely with AMR. I hope that answered your question, Chief.
Yes.
Madam Chair, it's Michael Urquidez for ALS Fire. I have a comment.
Yes, go ahead. Thank you.
Teresa, thank you. This was a great presentation, and I think it really opened our eyes of really what occurred. The research that I've done, because I've raised this in the past of having a presentation by AMR, but I think this met the intent, is being a rural county, going from 2,500 calls in priority to 200 calls to 250 calls. The opportunity for error is just one call either way. The pot of recovery, meaning the calls, is such a slight error of margin. I guess a margin of error is a correct term. And when you look at other rural counties that are, the size of Monterey County, there's very few that have a population of 450,000. It seems like we've made a fairly aggressive standard. I do kind of agree with what AMR is asking is, combining that, the priority 1 and priority 2, in a rural county, this is going to always be a challenge, and more so right now during COVID. But when, South Monterey County has such limited ALS coverage, it's 100% based on the county's provider, no ALS fire departments. It really puts the burden on the contractor, and it's just going to be an opportunity to generate more fines, which the end user, the patients, have to pay for, and does nothing for system enhancements as far as reducing bills or anything like that. So I'm just curious, with your contacts of other LEMSAs throughout the state, have you seen what we're doing here in Monterey County in other LEMSAs that are rural in nature, and not a million people within, a much smaller square miles coverage. And it just seems like this is destined for challenges for years to come. Because let's face it, Monterey County is not really booming with 1,000 home subdivisions in the pipeline. I think Salina City has probably the most potential growth, and but it's probably 30 years for them to build out for their additional 15,000 homes that they're looking at. So I just seem to be that it's going to be a constant challenge for the provider, and I just see a lot of additional work. Their contract seems to be clear that under disaster declaration that they could, it just seems like we're nickel and diming every call, that if they submit it to you, you find out if it's good or not. It just seems to have to be a better way for your staff and your time to, I can speak for my agency and all ALS agencies because no one's brought it to my attention, but we're not seeing, 2-hour response times. And I appreciate the work of the contract compliance group. I'm just wondering, do they get to see the calls that are submitted under what you're proposing? Is that AMR can turn in and you guys will review it or deny it? Or is that call, for example, and the outcome that you've determined, does that go to the contract working group so they can kind of see the particulars? Thank you.
In terms of the particular calls, that we started drilling down into the data. And in terms of the calls where AMR did not meet response to compliance, because we are drilling down, that is one of the reports that is going to start going to contract compliance working group. I think I lost my train of thought on the rest of your comment, but we're not trying to nickel and dime the provider. But we do need to watch, we still need to watch the system. Even if you combine priority 1 and priority 2, there are still going to be calls that are going to be late. And when it comes to priority 1, we should pay very close attention to those calls. Like I said, the EMS agency is open to exploring other ways of even calculating the response and compliance. It may be better. But like I said, we are doing our due diligence. We still have to address the issue of, what do we need to do? We're not expecting AMR to get to every call on time 100% of the time. That's why we measure the 90th percentile. I also mentioned in terms of penalties, we're not nickel and diming the provider with penalties. The EMS agency did not charge any penalties to the provider in 2020 because of COVID, and because of that, the provision that we agreed to waive those penalties after the implementation of NPDS. So it is not the EMS agency's goal to assess penalties to the provider while we are dealing with the pandemic.
Thank you.
And then, Madam Chair, Tino from AMR, I just wanted to respond to some of Mike Urquidez's comments, if I may.
Sure, go ahead.
From an AMR perspective, I think we've been very lucky to have good partnerships with the fire departments, rural and city, Carmel Regional Fire Ambulance, and of course, Monterey Regional Fire Ambulance that actually helped us in mutual aid areas that actually got us to a point, and also our AMR counterparts in San Benito and Santa Cruz that do respond into Monterey County to help with those areas that are hard to serve, which have actually got us to areas to compliance above 90% after COVID had hit. Without their help, I think our compliance would have been worse. Again, we are challenged every day because we are in a state of emergency nationwide, worldwide, and we are making every effort to keep our staffing up to the levels that were prior to COVID, and that is very difficult. One of the things we've done, and I've repeated it before, we've put over 8 paramedics through our scholarship program, and almost more than half of them have left to other fire agencies, which decreases our staffing levels. So things like that we've actually worked, we've financially have increased our stipends as well as our signing bonus for our new hires to recruit more folks every day. So without the help of our system partners and with the continual work with the agency, I think we've been successful in a lot of areas, but other areas it's always a moving target. So we're always trying to capture those calls. And again, fire departments get there, law enforcement gets there, they start the initial CPR if it's needed within the first 2 minutes. That's what we want. The ambulance is shortly there behind them within 8 to 10 minutes, depending on where the call's at. So those are our true first responders. Same thing with EMD. They start the initial CPR instructions, and that's how a system's supposed to work. Everyone's involved, not just the ambulance provider, because without your guys' help, the patient outcome wouldn't be positive. So thank you.
I've got a question about staffing levels. Do we know how many EMS personnel have come down with COVID in Monterey County? How that's affected staffing across the board for police, fire, and ambulance?
We wouldn't have the data. No.
We should, so that tells us a picture of what's going on though.
Is that something that you, Tino or Mike know?
I mean, the challenge would be is that I'm not sure what we would be able to release, but it's not even just specific to, COVID positive employees that have come up. It also has to do with the quarantine procedures as well. So, sometimes just an exposure to another employee who may have come up positive, we have a quarantine period that we put them through. And one thing, if I could also add that I think is really key too, that, Chief Penholzer had asked about, is that we have in the last 2 years, we put up an emergency paramedic program up at Watsonville Hospital, worked with them. And this year we put up a program over 2020 with DFib up in Santa Cruz County. We have another program that's going to be starting in March where we have 12 seats, and we're working on a second program that could start in April or May in that time window as well. And a lot of that is just dependent on, preceptors and those types of things. So we are aggressively, the scholarship numbers are the highest that I've ever seen. And then also we have been working out some aggressive hiring bonuses. We have a $15,000 sign-on bonus now. We also have referral bonuses, and also looking at some of our harder to fill shifts, exploring the option of maybe incentivizing those as well. But at the end of the day, we also have to be fiscally responsible and, make sure that we're creating a viable system. So, but we do work through those. But back to the original question, I would say that, in general, without providing specific numbers, I mean, we're impacted definitely by COVID daily when it comes to quarantines and those types of things. Not a very eloquent response, but it would be challenging, I think, to provide specific numbers daily.
This is Tina Nieto from Law, and it's the same with the police officers, because obviously we're separate agencies. However, when talking with the other chiefs in the county, we've also been, as far as personnel, been affected both with officers coming down with COVID, and then also the quarantine procedures when there's an exposure. So, but again, we don't have, the total numbers for the county.
The other thing too to mention is that the state has the COVID paid sick leave. And so that also, that if you have a family member at home that has it, or, that you can be on sick leave. So that I know is affecting the hospitals. I'm sure it's affecting the agencies too. So that's just another added, challenge.
It just gives us a good perspective of what we're losing.
Sure.
For contract compliance, not just AMR, but all the first responding agencies.
Absolutely. Yep.
And it's not something you need weekly, but once a month if we've lost 22 personnel this month due to this or that.
Well, I think one of the other things that helps the system is we've been included or added BLS units to help with these out-of-town transfers, because some of the hospitals have been overloaded and there's been an increased demand to move these patients off out of the county for other specialties. So I think having BLS in place for that has helped. I would love to entertain having BLS into the 911 system for low-level Charlie or Bravo calls, 5150 transfer from scene, because I think that would help again. But operationally, things have changed because after COVID, we're taking longer to decon, and if a person now feels that they've been exposed, or they now get removed to go through a process to ensure their safety and their health is taken care of. So that increases our time on task. And again, it's COVID. Our operations have changed. We're no longer clearing our hospitals, dropping off our patients, and going to the next one. As the guy in the back is wiping everything down, we're not doing that. We're now taking more time with that. And that's hard to document at times because some of the CAD systems don't give that capabilities, and it's only in the notes. But anyway, that's a whole different issue. But again, thank everyone for helping us out. I think it's been great, and we're moving forward to meet those response times.
Well, one other aspect of this is that the contract compliance working group does look at hours lost. We don't look at cases that lost due to COVID or whatever have you, but look at total hours lost. So it's not a direct correlation, but it's at least a positive correction, a viable indirect correlation that is available to us. And obviously, that has increased over the COVID period.
Okay. I think any other comments, questions? Okay, let's move to item 5, EMS system performance metrics. Jeff?
Estella, do you have, are you able to bring that up?
The one that I.
Yeah, just the last graph.
Yeah, I think that's just separate. 8 times?
No, I went over 8 times.
Yeah, that's what
She covered
Okay.
that.
They kind of all went together.
We're gonna share the graph there. This just is real quick, 1 minute of your time here. The 800 megahertz daily radio testing. I guess the key thing to look at is the standard that we hope to achieve through AMR dispatch is 95% of the tests being made to the 4 hospitals each day. And last month AMR got to 93%. So we're, which was a great improvement over November, which was a bit of a drop there. But we've got the whole 2020 there over the last 12 months. And that's the big picture for 2020. It's worth noting that on December 17th, AMR dispatch moved to our location here at Schilling Place out of the comm center near Natividad, and the 800 megahertz, the hardware, the radio hardware was still at Natividad and is here now, but there's just throwing that out there in terms of numbers that the December month, and that it's accurately reflected. We did a 17-day month, and that is the percentage there for that. And the radio, the 800 megahertz radio equipment is here now at Schilling Place. So we'll be, AMR will be picking up where they left off and resuming testing.
So are all the systems up now, or are they still being?
It's up here now, yeah, tests are being conducted. And I appreciate AMR for providing us with that. And so we don't have, I don't know if anybody, if Tino or anybody wants to speak to November. I don't have any information on that aberration there, but we're glad the numbers came back up in December. So, any questions?
Yeah, I would yield to Liz Vega, our comm manager, on that for the 800 megahertz. But we did move over. There was some problems with connectivities at times, and but ITD and county communications were immediately at our service to help us out. And I don't think we've missed any calls or had any big issues. So I think the move has been great. The dispatchers are feeling comfortable there. They've been well welcome. I think the EMS agency has really stepped up to help us with that transition, and we're really grateful for that.
Okay, so we had, any other questions, comments? Okay, the next item, the APOD times, we already did in Kimberly's presentation. So we'll move to item 6, old business, and a report from Teresa about the RFP.
Thank you, Chair. The committee has been wanting to have this as a The committee has wanted to keep this as a standing item while we go through the RFP process. There's not much of a report other than that we release the responses to the written questions that were submitted to the EMS agency related to the RFP. That's the end of my report. Okay.
Teresa, are those answers online to the question and answers?
Those are available on the contracts purchasing website, and anybody who was on the distribution list should have received an email with information.
Thank
And then the next item, item B, back to Teresa, the EMCC membership.
The EMCC membership, we are still in the process of recruiting for the third citizen rep. We have some leads for individuals from South County. We are also trying to recruit the alternate. We're trying to make sure that we have the representation from the county. At the request of Harry the last time, he suggested that we reach out to individuals from the hospitality industry. So that's what I am working on. Other than that, that's unfortunately that's the only report I have at this time.
Okay. Any questions or comments for Teresa? Okay. And then going in to item 7, new business, AMR's request for a rate adjustment, and back to you, Teresa.
Is that Teresa?
Just leave the mask up.
In your packets is a staff memo that talks about AMR's rate adjustment request. We received that on October 29th. The EMS agency reviewed it in accordance with section 17.2 of the agreement that clearly spells out the methodology by which the rate adjustment is to be calculated. It offers 2 options. Automatically, AMR is entitled to the greater of the 2, and based on that calculation, there would be a rate adjustment of 8.4% that would go into effect on, they will go into effect on February 1st. Because it is not outside of what the contract prescribes, it does not require board approval. It just an automatic adjustment that will go into effect, and attached was to the staff report was AMR's letter requesting the rate adjustment and the new table with the new rates.
Any questions, comments about that? On to next item, future EMCC agenda items. Did we want to add anything to the agenda for next time?
I know Harry mentioned the endorsement.
The change to the calculation of the calls that go through EMD.
Yeah.
We'll bring that back next time.
So we'll, Harry, we'll bring back the change to the calls going through EMD, the endorsement that you had talked about. We'll bring that back to the agenda next time.
Yes, thank you.
Anybody else? Okay, and next item, announcements for the good of the order. Anybody have any? A member of the committee can make announcements or comments. EMCC may not discuss or take any action on any item raised during announcements except to decide whether to place the matter on a subsequent agenda. Any announcements? Okay, hearing none. Next meeting is scheduled for March 10th, Wednesday at 10:30 a.m. And that is it. We will move to adjourn.
Everybody be safe.
Be safe.
Thank you.
Take care. Good meeting.
Thank you.
Thank you. Thanks, Sam.